So I'm going to give you my view of CAR T cells and try to make sense of what CAR T cells are and what is their role in CLL now at this moment in time. So the important thing to remember, why do we need the CAR T cells in the first place? What is the reason behind it? And the most important thing that in any cancer patient, there is a fight between the cancer and the immune system. So one of the natural ways in order to get rid of cancer is our immune system. And actually the T cells, the T lymphocytes, so CLL is a malignancy of B lymphocytes, but the T lymphocytes are very, very important cells to prevent cancer. And there are types of T cells which specifically do that all the time in our body. So in order for the cancer to win that battle, it needs to make some changes in our immune system. It needs to hide itself from our immune system so that the T cells don't recognize that I need to get rid of this cancer cell. It feels like when a cancer cell comes in our body, the T cells see that as a foreign cell normally. And if it sees it as a foreign cell, it will get rid of it. The way the cancer decides to overcome that problem is by masking itself so that the T cells don't recognize it as foreign and feels it like self. And then it breeds out and then grows. And then essentially its armies are so big that it overcomes the T cells. Normally the immune system distinguishes self from non-self. And these are the two important things what immune system is doing. The main job of it is to get rid of infections. But when we have got too active immune system, it attacks the own cells, causing autoimmunity. So some of the autoimmune disorders like rheumatoid arthritis and lots of other diseases are because our immune system, these T cells, are too active. So there needs to be a very fine line, really, which the immune system needs to keep on with it. And it does a very fantastic job normally. So what happens is that when you've got a very overactive immune system, your balance shifts towards autoimmunity. And when it shifts towards the other side, patients start getting many infections. And that balance is very, very important to keep. And when we talk about the treatment with cancer immunotherapy, and CAR T cells will fall into that category, we bend the immune system curve in such a way that we can eliminate the cancer here, but we avoid the autoimmunity. So it's now, you can see it is like a curve where we really want our immune system to hit the cancer, but avoid the autoimmunity as well, which is quite difficult to do. What happens when we get a tumor? This is for any tumor, any cancer. We've got the tumor cell here, and what happens is that there are cells in our body called the dendritic cells. We all have them, that they are the part of our immune system. They eat up this cancer cell. And the cancer cell is then presented to these cells called the T lymphocytes, and the T lymphocytes will get rid of it. So it needs a very intricate balance actually for this immune system to function properly. And when I was talking about is that the host immune system is an active enemy faced by a developing cancer, and all successful cancers must avoid immune destruction. And once they overcome that hurdle, then essentially they start to grow and cause problems. So the ideal cancer immunotherapy target is they overcome the fact that cancer is self. It needs to break the tolerance, help immune system see the target as non-self, as foreign. And that's where CAR T cells are beautifully designed to do that. Why they help to break that tolerance and helps our immune system, or those recombinant T cells, to actually see the target, the cancer, as non-self. And we ideally want them to only kill the malignant cells and don't kill the normal cells in our body. And they are necessary for the cell survival or malignant phenotype. There are two ways by which we can accomplish that. There's some antibodies that we can give that can do that process, and then there are T cells which can be activated by vaccines, and there are some drugs which affect the tumor microenvironment, or we take out the T cells, the last one here, change them so they're specific for the cancers, and that's what CAR T cells are. So in simple plain words, it is quite a nice way to see that you want this thing to be taken off so that the cancer could be removed by the T cells. So what is chimeric antigen CAR T cell therapy? In very simple plain words, T cells are a type of white blood cells which are taken from the patient themselves, or they could be taken from another donor. And what they do in the lab is that if this is the normal T cell, they make some changes in these T cells in such a way that these become very potent machinery to recognize the abnormal B-CLL cells. And what happens is that these CAR T cells are then multiplied in the lab to very high numbers, and that's why there is a lag between where we take the cells from the patients, and there would be about 4 to 6 weeks before they could be reinfused back, because in the lab what you're doing is putting them through the chemical process of multiplying the T cells over time, and once you've got enough numbers, then you reinfuse it back. The benefit of that using your own T cells is that our body would be able to recognize that these are my own cells, and they won't have that problems that you get with allogenic stem cell transplants. And lastly, when CAR T cells come in, they attack the tumor cells. In case of CLL, it's the CLL cells that it will attack and essentially try to get rid of that. And there are two ways to achieve that with CAR T cell therapy at the moment. One is called allogenic CAR T cells, and this is taken from a healthy donor, and essentially the same process is applied and given to multiple patients at this moment. Now, allogenic CAR T cells are being trialed at the moment, and there is a benefit to it. If we can make them safe, then this is an on-shelf product. So you can take it from a healthy donor, and you can devise them to what you want to do, and you can just take it over the shelf and give it to the patient, which is actually saves us the time. And one of the problems we see with other cancers like ALL, acute lymphoblastic leukemia, that grows very quickly, and we sometimes don't have time actually to wait for 4 to 6 weeks, because in that time the patient's leukemia would have relapsed. So there is a good role of these allogenic CAR T cells, and there are quite a few number of trials that are happening at the moment looking at that question. The traditional one, which we have used quite a lot, is autologous CAR T cells, where it is your own T cells and there is a lag before we can actually give it to the patients. But it is, if you can see, only for individual patient. You cannot infuse it in another patient. So this is the process, what happens. This is the T cell collection. This is the patient. You have a cannula in your arm, essentially, and we take the samples out. The machine collects the white cells, and we fractionate them, and we just are interested in these T cells. Machine does that job for us fantastically, and that's taken to the lab, and this is actually a virus. And this virus is infected into the T cells, and it is a very safe virus, actually. So it is not one of those which is going to cause problems. And essentially what it does is it puts out this DNA into the T cells, and what it does then over time is express these antigens on the surface of T cells. So if you remember, normally these T lymphocytes won't have this antigen here. This is the CAR T cell, the chimeric stuff, which actually wasn't there beforehand. So the virus transfects that thing onto the surface of the T cells, and then it is given to the patients. But before you give it to the patients, normally we give what we call as lymphodepleting therapy, which is primarily chemotherapy, and it is primarily to dampen down the immune system in the body, and this is very frequently that we do it in the transplant setting anyway. And what we found that actually if we don't do this process, some of the CAR T cells would develop antibodies against them and actually won't work that well. So this appears to be an essential process before we start monitoring the patients like we normally do with looking at any evidence of disease left by doing a CT scan or doing the flow cytometry or doing the PCR analysis. And then the last thing is important, that we also try to measure if there are any CAR T cells left over time. And what we can see at the moment is that CAR T cells tend to disappear about 3 to 6 months after we give it to the patients, but in some patients do persist. And I was having a talk, having a chat with Brian about the memory T cells, and there is a specific type of memory T cells which actually do persist in patients, and you can find them in very small quantities, and actually they are showing to be a very good marker of achieving long-term remissions in patients. So that is something that we will be looking at. Now the problem with CAR T cells is the first CAR T cells were made actually in 1989. So this concept is not new. It was done in Israel in the first place in 1989, the first generation CAR T cells, and it took us a long time to actually develop them into second generation, third generation, and now fourth generation CAR T cells. The way to explain these CAR T cells to you is that this is the tumor cell, and this is the T cell. And what is hanging here is what we call as the T cell receptor. And the T cell receptor has got these different names, alpha, beta chain, delta, epsilon, zeta, but they talk to the internal molecules here. So this is inside the cells. And this is a normal T cell function. What CAR T cells do is have this thing here, which is outside the cell, and it recognizes the B cells, the CLL cells. So what we have done with chimeric antigens is that expose these molecules on the surface of T cells, which was not there, and this will recognize this as CLL cell here and binds to it straight away. And these molecules, the CD28, CD3, these weird names, basically these are the stimulatory molecules. So when a B cell or a CLL cell touches the T cell, what happens is you get the stimulation of the T cell. And when the T cells get stimulated, they attack the B cell. They try to get rid of the CLL cell. And that is very important. If we didn't have these stimulatory molecules and only had this, which was the first generation work, that didn't seem to work that well. When we added the stimulation here with this combination, actually we saw that the T cells are now killing the B cells or the CLL cells. What is happening with the third generation ones is you're combining more stimulatory molecules so that you get very, very potent effect of T cells killing the B cells. And then you've got the fourth generations, which are called the truck. And essentially they also what they do is they stimulate other part of our immune system to release some chemicals called cytokines in medical world. And when you have got cytokines, you get more immune cells there to actually get rid of so trying to improve the potency of the CAR T cells. Does that make sense? Is that clear? I won't go.
What does truck stand for? We know what CAR T stands for, but what does truck stand for?
I can't remember the exact acronym, but essentially it's an easy, it's not an easy acronym, but essentially it is somewhere in that comes cytokine stimulation as well, but I can't remember. Yeah. But the problem is that you've got loads of these which are being produced now. There is pooled CAR T cell product where you combine the two type of CAR Ts. You've got multi-CAR which are joined together. You've got tandem CAR T cells which are joined together. The conditional CAR T cell, then there's split CARs, inhibitory CARs, And there is this thing called the suicide switch, actually. So in some patients where CAR T cells are causing a lot of problems with increased chemical storm that you're seeing in some of the patients, you can induce a virus into these ones, and actually you can switch off that. So there is a suicide virus in there which will switch off those CAR T cells when you need to do that. And that technology is being developed at the moment as well. So I think, why do we need the CARs? I think it's the best of both worlds of the immune system. You're attacking the CLL cells specifically, but you're also seeing the T cell cytotoxicity, which we want them to do. They are synthetically engineered, and they target the surface molecules. And the important thing is that they don't need other part of our immune system to work with them. So when I was showing you the T cell initial one, you needed those dendritic cells and other cells to help these T cells to be activated. The CAR Ts don't need that. They can do it on their own. We need the ideal CARs to be tumor specific, and the molecule that we use on the CLL cells is this molecule called CD19. And it is a very specific molecule on all the B cell malignancies that we see. So that apart from myeloma, nearly all the cells in the B cell lineage actually will express CD19. So it is a very good marker to look forward to. It's not free of side effects, and that is a problem with the CAR T cells. And the reason for that is that when you're asking something to kill off a B cell, what will happen is that you can get this kind of phenomena called the cytokine release. Or simple word is that essentially, if you have got a raging infection, what happens is that your body tries to react to it. And the first thing it does is raises your temperature. And you can have chills and rigors. It's similar to some people might have had rituximab given to them. And as a first reaction, they might get an infusion reaction. And that's the natural body reaction to do that. Now, when then the T cells are reacting with the CLL cells, similar thing happens actually. And you release a lot of chemicals. And at that time, what is happening is the T cells are getting signals to grow very, very rapidly. And it's an uncontrolled way. And at that time, people do get very high fevers. People do feel unwell. And some patients have to go to intensive care units so that we can keep their blood pressures under control, try to keep the things well tolerated. And that's where sometimes the switch on off might be very useful so that you're able to control it a bit better. We can control that with giving steroids, and there is a drug called tocilizumab which blocks a protein called IL-6. That's one of the chemicals, and essentially you can give that to the patients, and that actually works quite well. The other thing which happens is that the normal B cells also express CD19. So the CAR T cells actually wipe out the normal B cells as well. And as a result of that, some patients will have depressed immune system, and nearly everybody will need immunoglobulin replacement throughout till their normal B cells start to recover again. But essentially, immunoglobulins are required in majority of the patients. One thing is for sure, that whenever we played with T cells in the past, either with chemotherapy drugs or new molecules, what we find is that the T cells like to go into the brain. And we can find the CAR T cells in the cerebrospinal fluid, which is outside the brain tissue. So they like to go there. And sometimes what they can cause is some neurological side effects, which can mean that when the temperatures are very high, patients can get fits. That can happen. Some patients get headaches. And generally, what happens is that once the cytokine storm settles down, this complication also gets better. So there is a price to pay, actually, when you're having CAR T cells. They are very useful for patients, in limited number of patients who do need that, because we need to make it more safe at the moment, because simply at this moment in time, there are some complications related to it, why we cannot roll it out to all patients. So Brian will tell you his story, and I think you will get the flavor of that, why that is important step, and actually it might be able to cure some of the patients. CAR T cells are not only used for hematological malignancies, but as Michael was saying yesterday, 10% of the Ireland funding going to the hematological cancers, 80% of the evidence that CAR T cells work come from hematological cancers, only 20% in the solid cancer domain. Some of the tumors might lose the target, so sometimes the CD19 disappears altogether, and if CD19 disappears, the CAR T cells won't be effective, so it's very important to look out for that. And there are technical challenges, but I think we know what we're going to do in terms of allogeneic T cells might be the answer to that. And sometimes you get the exhaustion of the transferred T cells, which is a complicated thing, but essentially that we can most probably come around it with few techniques. So just in CLL, so this is a nice diagram of a CAR T cell. This is the tumor cell or the CLL cell. This is the protein which is the recombinant CAR, and essentially these are the co-stimulatory molecules going into the T cells. And essentially it's exactly the same what I've told you, and there is a number of trials now which have been done, and this is from Turtle Group, David Maloney's group, and essentially 18 patients, average age was 60, all patients had fludarabine and rituximab, all patients had ibrutinib before, 11 of those patients with ibrutinib refractory, some of the patients were venetoclax refractory, complex karyotype, so really the bad risk patients. These are the patients who have had really all lines of therapy and could not be treated with anything else. And you can see that the overall response rate, even in this group of patients, was 76%. And the group of patients who were achieving complete response at 100% PFS at 2 years, which means that if the patients went into CR and very deep remission, actually these were the patients who are most probably going to follow that flat line, which is exceptional basically in that. There's no other drug or no other treatment in that group of patients which will achieve that. We found out that if we give very high doses, these are 20 million cells per kilogram, that's too toxic, so the dose was reduced, and this is the cytokine release, and it was seen in majority of the patients, but only 4 of the patients had neurotoxicity. And some patients required more lymphodepletion, which means chemotherapy before that. But not all the data is very clear in CLL with CAR T cells. So this is multiple groups presenting their data for CLL, and this is Pennsylvania group, the 2010 publication, first 3 patients, all of them had a very good response. But when they went back in 2014, 24 patients and 10 out of 24 had a response. So it means that we need more experience really, and only small number of patients will not give us an answer. If you see a slightly different construct of the CAR T cells, so the NCRI group had a good response, whereas the Sloan Memorial Kettering one wasn't very good. So it's very important how you design the CAR T cell. So in myeloma, it's not CD19 that we're using, it's BCMA, the target, and the proteins, co-stimulatory molecules are very different. So for each cancer, we have to be clever and see which is the right way to stimulate those T cells. So previously, we had surgery as a radiation, chemotherapy as the pillars of cancer therapy. We've added the targeted therapies, and we had a good session yesterday about it. And immunotherapy has been going on for some time now, but now it is coming into its own and getting into clinical practice. So I think there's no doubt they are an exciting addition in our ability to treat CLL. The initial results were relatively poor as compared to what we saw with acute lymphoblastic leukemia or diffuse large B-cell lymphoma. The response rates were 80% in those group of patients. So in CLL patients, maybe because of the complications related to the CAR T cells, we didn't see that many good responses, and clinicians were very, very quick to kind of deal with the complications of CAR T cells while reducing the efficacy of the CAR Ts. But we are getting more used to them now, and the quality of CARs is really improving, and I think that would be the game changer. If the CARs become more palatable and the side effects are easier to manage and they retain their effectiveness, that's where I think the money lies really at this moment in time. The one thing which is missing out of all is the long-term data, because we need 5-year, 10-year data to look at that. But the initial data looks at the short-term time points look very exciting in that respect. And something which is not clear is the toxicity profile of these CARs is not clear at the moment. Some of the CARs are relatively not toxic, and some are very, very toxic. So we need more data on that. And that's why clinical trials are the most important thing, because we can monitor that very, very quickly. There are more questions than answers at the moment. The question really in my mind is that if we have patients in very good remissions, do we introduce CARs at that point at very low dose to get them into very, very deep remissions and get them into, or we should be using that just in relapse setting where actually everything is raging. So by that I mean that if you have a very high tumor bulk and you need a lot of CARs to deal with that, you are most probably going to have a massive fight between the two, and then you might have more complications. Whereas actually if your disease is very low burden, then we can give you small amount of CARs and actually try to win that battle quite easily at that point. So I think all of those questions are out there at the moment. We don't have the answers to that, but in the next coming few years we will. So I think they are coming. We are going to do some trials on those as well in Leeds, and I would be very happy to come back and let you know what I think. How did they go? Thank you.